Good afternoon to one and all. I would like to express my thanks to Dr. Sahasnama sir and KSOS for making me part of this IC. I am going to discuss the role of imaging in unexplained defective vision in children. When a child presents to our clinic with complaints of defective vision, we usually think the causes to be like either a refractive error related defective vision, or any associated problems due to amblyopia, or any strabismus or even microtropia related defective vision, or any media opacity from cornea up to the retinal layers, or any visible syndromes or associated with ocular injury, or any posterior segment pathology. When we examine the child and do the needful examination, if there is no refractive error or no features related to amblyopia or strabismus, media is clear, no visible syndromes, no ocular injury or posterior segment pathology, we will be puzzled, and here comes unexplained defective vision. So we need to dig more. What is the cause for unexplained defective vision? Nothing is seen during the initial examination. It may be due to some hidden optic nerve issues, or any causes due to cerebral visual impairment, or some intracranial pathologies not yet identified. Sometimes maybe a migraine with aura, or any genetic or nutritional problem, or sometimes rarely non-organic causes like malingering. So during this time, we need to do a much more detailed history and examination. A thorough detailed history including the antenatal, postnatal and the further developmental history. Also family history, whether any associated defective vision or any related disorders in the family, and we need a little more detailed evaluation from the routine procedures. We need a full cycloplegic refraction and the orthoptic examination, color vision, OCT imaging of macula, RNFL and GCC, fundus photography, electrophysiology and imaging will be needed in these cases. What is the role of imaging in an unexplained defective vision in a child? Unexplained defective vision with any RAPD or sluggish pupil, any newer onset nystagmus, especially vertical nystagmus, any nerve palsies or newer onset squint, or any optic disc changes like disc edema, pallor or atrophy, or systemic features of raised ICT or any other systemic features suggesting neuroimaging, we need to proceed with imaging. MRI brain with contrast or CT orbit in suspecting orbital pathologies, and selected cases we may need MR angiogram or venogram and digital subtraction angiography. We will discuss few cases. A 9-year-old girl present to OPD with defective vision for 1 year. She was evaluated in multiple places and during camps also. Her uncorrected visual acuity was 6/18, not improving to any refractive error with glasses. Anterior segment, pupil and orthoptic evaluation, everything normal. Cycloplegic refraction also within normal limit. Only positive finding was bilateral temporal pallor. She was not able to do a reliable HFA. OCT, RNFL and GCC reveal temporal fiber loss. We want to rule out intracranial space occupying lesion. So did the brain, MRI brain with contrast, it turned out to be normal. When the patient came with the MRI report along with father, we re-evaluated the history. Father also gave the same history of defective vision at the age of 18 years, diagnosed when he was going for an army recruitment. Wife was normal, mother of the child is normal, and the elder brother is also normal. Only father and the daughter is affected, possibly a familial optic atrophy, advised genetic evaluation. Another case, a 10-year-old boy, teacher noticed defective vision. All normal development, siblings and parents were normal. Uncorrected visual acuity was 6/36, not improving with glasses. Fundus, subtle macular RP change is there. So possible diagnosis of early chondrodystrophy or early Stargardt's was made. Macula showed severely thinned out with EZ loss, highly suspicious of Stargardt's. But due to profound visual loss, that is 6/36, we advise ERG turn out to be normal. To rule out any brain-related pathology, MRI was done. It was also normal, so now he is undergoing genetic testing. Another case, 8-year-old boy came with complaints of defective vision, not able to copy letters. His preterm, he was a preterm long neonatal ICU with developmental delay. His vision was not improving beyond 6/12. Microcephaly was there. He is mildly hyperactive. All the examination was normal except for a minimal temporal pallor. On further reviewing all medical records, neonatal period reveal periventricular leukomalacia changes. Probably a CV-related visual impairment was diagnosed. Advise MRI brain in this case to know what is the extent of PVL changes at present. Here the MRI was done to know what is the extent of PVL changes and to prognosticate the vision improvement. Another case was a case of 12-year-old boy came with complaints of headache and defective vision. He was obese, not using glasses. He was having a significant refractive error, not improving beyond 6/24 in right eye and 6/18. He was not using glasses regularly. So, fundus, there is a mild hyperemic disc with blurring of disc margin. Possibly there is a, it can be related to either compound myopic astigmatism with amblyopia, but due to this fundus changes and obese nature, we want to rule out intracranial pathology, advise brain imaging. Another case, a 11-year-old girl came for glasses. She was using glasses for the last 4 years, but not improving beyond 6/9. Here we advise MRI because she was having a persistent giddiness. MRI was advised from ENT side and turned out to be an astrocytoma was there. So role of imaging is for diagnosis, to rule out intracranial pathology and to prognosticate vision improvement with glasses based on structural damage and as a part of follow-up in unexplained defective vision. Thank you.